Good evening, everyone, and a warm welcome to all the attendees to our sixth session of the Knowmics series. I'm Aarti Dara, bioinformatician working at Karkinos Healthcare, and I'll be your host for tonight's webinar. And we'll also be leading the Q&A session after the speaker's presentation. Today, we have with us Dr. Chepsy, a distinguished professional in the field of clinical hematology, and he will be delivering the talk on significance of genomics in the field of hematology. Dr. Chepsy has obtained his MD from CMC Ludhiana and did his DM in clinical hematology from CMC Vellore, after which he was trained as an ACA fellow in blood and marrow transplantation from FHCRC, Seattle, USA. Dr. Chepsy expertise include bone marrow transplantation, chemotherapy, and immunotherapy for diseases of the blood and marrow, which includes multiple myeloma, lymphoma, leukemia, anemia, thalassemia, and many more. Currently, he is serving as a program director for Raktam, a center at Believers Church Medical College Hospital. Raktam is an acronym for Regional Advanced Center for Transplantation, Hemato, Lymphoid Oncology, and Marrow Diseases. The center specializes in various aspects of blood-related diseases and treatments and approaches, based on the personalized care and precision to ensure the best possible treatment outcomes. For his excellent contribution to the field, he has been honored with the American Society of Clinical Oncology International IDEA Award, and his current focus is on establishing an advanced center for hematology and hemato-lymphoid oncology in Believers Church Medical College Hospital. He is strongly committed to delivering hope to all those affected with diseases of the blood and marrow. Without further ado, please join me in extending a warm welcome to Dr. Chepsy. And as a reminder, I would request participants to not interrupt in between the presentation, but post their questions in chat, which will be taken up at the end. The stage is now yours, Doctor.
Thank you, Dr. Aarti, for a very, very generous introduction. I'll just start off with sharing my screen and also thank Dr. Vinod for giving me this platform. So just to check, are my slides visible and I'm audible?
Yes, sir.
Yes. Okay. So I am not personally an expert in NGS or in next generation sequencing, but I am fortunate to have been able to utilize these tools for a lot of our patients. So at least I'll give you the background. Like we all recognize that there has been a lot of changes in hematology, oncology per se. And every day we keep hearing of these new mutations which can affect prognosis or which can decide on a therapeutic intervention. And particularly as we are moving towards very personalized care, the criticality of this knowledge is now more than ever. But we all recognize that these are not tests which are easily available in our landscape in India, not in most centers. Many of us have to resort to outsourcing these tests, and many a times these are all very limited information that we get, because even now the real utility of knowing this genomic landscape in real world is not yet known or not that established as much as it is in particular diseases like an MDS or say acute myeloid leukemia, which is among the diseases a hematologist treat. But besides that, we also treat a lot of non-malignant causes. Many a times we might not have a diagnosis to offer them, but it leads to a lot of doubt and therapeutic uncertainty for these patients. So it was in one of these conversations with Dr. Vinod that we thought about exploring this potential tool, which has given a lot of information in malignancies per se, but also in helping us identify if these undiagnosed cases, which are there, which a lot of cases are there, and the amount of anxiety and stress that it conveys to patients, and it affects their daily routine and life. And we increase the burden when we add to it that, sorry, we are not able to diagnose what it is. And then there's a lot of movement across states, across hospitals, and it becomes a pilgrimage. And it is not fair on these patients because, to be honest, we don't have an answer to it, but their anxiety drives them to almost replace their life with stress at all times. So that was the purpose behind many of these tests that we have done. But we recognize that it has been a vital tool in malignancies like AML and MDS, and it has helped us enhance diagnosis, prognosis, and also decide on therapeutic intervention. So these five points just highlight the cases that we see, which are easy to diagnose, get diagnosed very fast. So if you're suspecting a malignancy, we end up doing a bone marrow. There is a flow cytometry that will confirm the diagnosis. In a setting like India, where many people cannot afford most of these high-end investigations, at least labeling the disease properly will guide them to choose at least the minimal treatment required for that particular disease. So if it is malignant, it gets clear cut sorted out. But there are certain patients who might have an unexplained leukopenia, white cells might be low, or who could have an unexplained thrombocytopenia, who might continue to be treated as say immune thrombocytopenia with steroids, multiple immunosuppressive agents, who for the lack of any further tool to establish diagnosis fall into this bracket where treatment usually fails to achieve any meaningful benefit for them. So we end up doing a workup. We do a lot of ancillary investigations like imaging, ultrasound to see whether there is spleen. And at the end of it, when we have nothing, we might end up doing a cytogenetics, fish, and all these tests, which are also in. It's a lot of financial commitment from the family also. So at our center, which is a not-for-profit center, we end up doing a bone marrow, a peripheral blood smear, a cytogenetics, and a fish. It is costing the patient 18,000. And at the end of this, when we say that there is no diagnosis, many of these patients might not have any further reserve to solve all this. So I think this is a wonderful tool which has the potential to replace all these multiple tests and give us exactly or even more information than the available tools. But this is a process which needs to be established more robustly. And we also recognize that there are certain diseases in which there is a lot of baseline mutational burden, in which diseases the genomic information that we give is going to be high. And till now, we recognize that all the stratification which we have used in diseases like MDS, MPN, they're very and they rely heavily on the clinical presentation of the patients. And so far, they have relied heavily on the karyotype and the fish reports to identify high risk and low risk. But it is possible that this genomic information was not available earlier, and it is likely that these high risk clinical features are probably represented by some mutational change, which could be picked up by genomics. That is something that the MPN group has identified. We now have the GIP score for the MPN, which is purely based on genome and not the clinical feature. So possibly we are likely to shift away to from all this clinical feature based staging or scoring to identify high risk, low risk, and decide treatment into this platform. And in a center like ours, or at least a majority of centers in India, probably work with resources which are very finite. We need to really utilize the patient's finances to provide him the best outcome. So if we can have a single test which can also offer us prognosis, which can also establish diagnosis at a reasonable cost, which a patient definitely invests in finding what they have, that would be a big service to many of the population in the country. So this approach is a little deviant. It has been explored in the West, where they've tried to look at what the real world scenarios are. But dominantly in our setting, unfortunately, it is restricted to certain genes, particularly the myeloid series, where the readout will only contain whether this is present or not present. And there's a lot of background information which could also establish a lot of diagnosis. So it is not that we are the first, or whatever I'm sharing is the first thing that is available, because work has already been done from the research setting. It is now shifting into real world practice. Now, this is a paper from the French group, which have been doing this NGS from 2013 on a research mode. But from 2021, I think there are certain parts or certain universities which have now started utilizing, or at least they have reviewed retrospectively whatever information they have on the clinical outcomes. So in this particular group, they checked for 177 retrospective data they had on NGS. And if you can look at the initial diagnosis before NGS testing, they were able to establish or narrow it down to definite malignancy or definite clonal hematopoiesis based on the NGS findings, and they were able to rule out in a significant amount of people. So this adds to greatly enhances our diagnostic efficacy. So this is based on retrospective review, and then they've also utilized this information to decide whether treatments can be affected. And from that whole cohort, they were able to identify mutations from that cohort and focus treatments based on this NGS value, which is not standard of care then, and to improve treatments in this cohort. So other than establishing diagnosis and also ruling out diagnosis, this is a valuable tool in using the available agents for better utility for these patients. Now, that was a retrospective cohort with one part which utilizes the information to change treatment. Now, this is a paper which Dr. Vinod had just shared with me on the PRISM trial on pediatric cancers, where they use this NGS to screen out high-risk cancers. And they tried to see whether the information from the NGS could guide different treatment. And they used one cohort where the NGS information was obtained and one cohort without the NGS information, and which was following standard of care. So if you can see the survival curves, there are significant differences even. So mind you, these are high risk cancers where you have very dismal outcomes. Even from this high risk cancers, this group has been able to tease out better therapeutic options based on the NGS, which are away from the standard of care and helped improve the outcome. So definitely, even in dismal situations, it is now proving to be beneficial. And this is very, very recent information that has come in. So gradually, I think this is going to replace or at least add the therapeutic armamentarium with the drugs that we have available. And just share the concept as to why this is it could be useful even in clinical practice. I just want to share this experience from the original GIPS classification, because prior to this, we were always going by the clinical features or the DIPS plus, the dynamic score for myelofibrosis. But when the authors here or this group, they tried to tease out this high risk features based on this genomic information alone. They were able to get off or take away all the clinical features and all the cytogenetic value into from the score and purely base it on this mutational profile. So I think this additional tool, other than helping you establish diagnosis, it also helps you it can also help you prognosticate, like how we have shifted in myelofibrosis. And then, like I showed you before, there is also a role of it helping our therapeutic armamentarium. So with this background, I'll just share the real experience that we have gathered along with Dr. Vinod's expertise into certain of our patients. So I already told you that we have the subset of patients where we end up doing the marrow, doing all these standard tests and not offer anything. And this is a big burden for the family, for the patient to carry. And if they end up in a hematology OPD, there is this inherent fear that it is a very fatal malignancy in many of these patients, and the burden they carry is very high. But if we are able to identify and tell them, "Nay, this is the mutation that we identified. So far, it has not been known to cause any problem, but it is a clonal problem, so it is likely to be there. Don't get afraid." These give a lot of satisfaction to the patient. It reassures the patient. And this day, everybody wants to know an answer. Like this we don't have an answer kind of concept really has not. It is difficult to practice that in India. But and then they'll end up and they'll get lost in a lot of follow-ups elsewhere. So this was a gentleman who was having this only isolated leukopenia and minimal thrombocytopenia. Was followed. He came to us initially in 2021, and then we did all this marrow and all these things, and we said, "Sorry, you don't have a malignancy," is all that we told him. And but he was not convinced. And then for 2 years he kept running, went multiple places, but the everybody said the right things, that it was not there, not there, not there. But this gentleman never got convinced, and the family was totally tense about it. A lot of prayers and all that going for him. And finally, he came back to us with a fever because he stays nearby to us. And this time, by this time, we had entered into this collaboration with Dr. Vinod, that if we have these cases, if we can screen them with this and identify anything. So for this patient, marrow was clear, but at least we were able to identify as an SRSF mutation, heterogeneous, but at least it could explain without dysplasia that this is likely a clonal cytopenia with unknown significance. And at least giving that name, we didn't make any change in the treatment, but we gave him a name that this is what you have. This is not going to take your life right now. You can live normally. And now he's a happy man. He comes to the OPD. His counts are still low, but he's convinced that just that wording, and that makes these are meaningful differences. Then same with this another gentleman that we had. So we moved away from doing cytogenetics and fish for all these patients, because if we can get in myeloproliferative diseases, if we have a suspicion, we are now going with this NGS or the whole exome right now, because it is giving us information in terms of classification. So for the GIPS plus also it helps us, and it also helps us in the diagnosis, because a JAK2 mutation makes it diagnostic. So now we are, as a practice, we have now shifted to just doing this single one molecular test other than the marrow for patients we suspect myeloproliferative neoplasm. I've just put in one example, a lot of examples that we have done in which that alone was enough to establish diagnosis. Yeah, so this is another interesting child that we had. So this was a girl with a developmental retardation, and parents were having this burden of taking care of her, also doing her rehabilitation program. But it had been around 6 years till when she finally came to us, but nobody was able to make a diagnosis on her. And she had a minimal thrombocytopenia to begin with, but this time she came with fever to pediatrics, and they involved us. And she had a particular facies, she had microcephaly, she had some skin lesions, and she had this leukopenia and thrombocytopenia. So our working diagnosis was it could be a bone marrow failure syndrome, and should we go ahead with the bone marrow transplant, was what our thought process what was when we did this marrow and we sent this reports. but uh, but this uncertainty in the child's diagnosis, as nobody was telling them why is the faces like that, and why does she have, I think she had a cleft palate also, it got operated, the speech was delayed. So that there's a lot of uncertainty in these families when they don't have a diagnosis. But what this particular test helped us do was it gave us a pointer that this could be a potential Seckle syndrome, a very rare syndrome, uh, in which all these growth abnormalities was explainable. And at least once we told them the diagnosis, the family broke down, but they were very thankful that at least now they have a name, they could connect, they could read the literature about what their child has. And uh, and now the patient is under follow-up. We're not doing any transplant or anything for this patient, because now we have a diagnosis which doesn't warrant a transplant. It is not likely to convert into a leukemia. So it gave us therapeutic plan, as well as a diagnosis for the family. Another case, yeah, another case. So I'm sharing a lot of interesting cases. We also have a lot of routine cases where diagnosis gets established by this test. But these are tests which have really helped the family. And this, if not for this test, I'm sure they would still be wanting to find out what it is, and a lot of uncertainty. So this was a child who came with who initially at birth had come to us from a hospital nearby with unexplained jaundice, which is not resolving. By the neonatologist had picked it that it is taking longer time tan usual, but we just said that it probably would be accentuated by the prematurity of the child, and we'll wait for some time. So they got lost to follow-up because the hemoglobin was stable and the child was otherwise well. And most of the pediatricians that he showed, they just said he's okay, otherwise we can leave it. But then he kept on having this recurrent jaundice, and then at 2 years of age, he came back to us again. That they went back to that original neonatologist, and he said, "Why didn't you go back to the hematology?" and that's how he came back to us. And we did the smears. We didn't really identify anything on the smear, and because the anemia was unexplained, we ended up doing a marrow. But this time we additionally sent this whole exome, and mind you, there was nothing on the smear, but this was able to pick out this potential ankyrin defect, which could explain his hemolytic anemia, which was there. And because it was mild, at least now we have a diagnosis. We've told him about it, and we've asked them to get a family screen. And also, this informs the family in case for another next child, if the same problem persists. Therapeutically, there was no need to change anything, but at least we now have told them that hemolysis is going to be there, and we don't have to keep on stepping up his HB because he has it maintained. So, therapeutically, also, it helped us make a plan. Yeah. So this another child who was repeatedly going to the dermatologist with multiple skin rashes. And finally, as part of the testing, she identified neutropenia in her and sent her to us. And yeah, this helped us establish the dermatological diagnosis as well as explain what the leukopenia was, which helped the dermatologist also fine tune their treatment, reassure the patient. Otherwise, the family, parents, they were just not able to go anywhere. People would ask them, why is the child having so much problem with the skin and the hair? And they had no explanation. And usually people become suspicious and they criticize the mother, and it was unnecessary problems. Now at least the family is reassured what it has. Another interesting child. So these, mind you, I've showed you many of these cases which are not hematological malignancies, but they have hematological problems. And I'm just highlighting how important and useful this tool has been for us to assure these patients with a definitive diagnosis. These are not chumma diagnosis. This is paka clear diagnosis. We have a plan for them and very reassuring for the family. Another child. Now, this is a child who came from the UK to us and had come. They are Malayalis. They had come for their routine yearly annual visit, but had this unexplained bleeding tendency from childhood, and also multiple fractures with not great injury. And in UK it is quite difficult for them to reach a specialist. So till now they have yet to see any particular focus clinician focusing on the problems that they have. They have a routine GP visit and with an advice to go to the university, which was yet to happen. But this time when they came to visit, she had another epistaxis and landed up with pediatrics who referred to us. And based on her, we were more interested and intrigued by the fact that she was having these fractures with very trivial injury. And there was nothing in the family, no history per se. Her counts were normal, but the epistaxis was also there. So we didn't have a clue in this particular patient. We thought it's some platelet function defect. And we went ahead with we did the peripheral blood. We didn't have to do the marrow for this. We did the peripheral blood for this patient, and the family went back to the UK, and then we got these results and we communicated with them, and we identified this particular mutation through the NGS, which could explain the bone mineral density, which could potentially explain the fractures that this child was having, and possibly one of those recurrent fractures in through the nasal bones might have led to the epistaxis. But at least we shared this report with them, and following our report, now they have been screened into a bone and joint clinic in the UK. And I think last week I got a mail from them asking about this report and saying that, okay, now she qualifies to be in that, whatever, they have a trial going on following up this patient. So at least uh, this unexplained problem had a name to it now. And now she's reached the right care that she has to get in the UK. And at least we have facilitated further treatment for that child. And again, this is again another non-malignant disease. So this patient came with uh, extrahepatic thrombosis. Suspected, we initially thought it is due to liver cirrhosis, that what he had was a Budd-Chiari. So that was the problem that the gastro was treating for, I think, 3, 4 years they were treating. over follow-up, they noted to have this hemoglobin staying in 16.5 to 17 range. And as part of workup, they decided to send to hemat. And because he had this, he had this atypical thrombosis, and his cirrhosis was not very old. It was just 2, 3 years old, and in the first year itself, he developed this Budd-Chiari. It was a bit unusual. So based on that, we went ahead and the fact that he had this polycythemia, we did this whole exome. We didn't do a marrow for him, and in this whole exome, uh, we picked out this factor 5 mutation, and potentially this could explain the Budd-Chiari that he had. At least it gave us assurance that I don't have to chase the polycythemia part, and I've just left him at that. We are only continuing the observation there, but at least because we've labeled him as a potential mutation which causes thrombophilia, we were able to advise continuous anticoagulation as much as he can. Yeah. This is a patient who turned out to be a malignancy. So this was a child, this was a young adolescent who came to us, 20-year-old, who had an extra thumb, and he came with a cytopenia. We initially thought it's a marrow failure syndrome, could be a Fanconi. We did a marrow and we also sent the whole exome. And in the whole exome, sorry, in the marrow, it came out as blast, and we labeled it as acute myeloid leukemia. And the family was extremely upset and extremely anxious. And by the time they were having a tough time trying to digest the fact that their child had AML. Luckily, this genomic report came to us. At least it helped us assure them that you have what is a good mutation that you have. You have an NPM1 mutation. They're likely to respond well with chemotherapy alone, and uh, and we were able to rule out any other marrow failure syndrome. So we don't really have to worry of using high dose chemotherapy. So this gave us therapeutic armamentarium. It helped our therapeutic choices and also reassured the prognosis in this patient with a malignancy. Yeah. This was another interesting case. So it came from government medical college to us. The pediatrician there was grappling with this hemolysis in this child. He had done an HPLC. It only had a trait. Was not really able to explain the hemolysis, and at least in the last 3 months was requiring 2, 3 transfusions, unexplained hemolysis. And he came to us. We did a smear. We didn't identify anything much. Hemolysis was there. TBTP was raised. The LDH was raised, but we didn't have much of a clue in terms of morphology. We only sent the peripheral blood again for this child, and we were able to identify this atypical form of HUS in this child. And at least it gave us a plan. We sent the child back to the medical college, and at least now there is a label to this disease. We are not chasing any more diagnosis. We are only treating as and when needed. Yeah, this gentleman was another interesting case. He was in our clinic. We had only diagnosed him initially. He came to us 2 years back, and we had an unexplained cytopenia and a little raise in his white cell count. We did a marrow, grossly normal, minimal dysplasia, but nothing very convincing for us to tell him that it is an MDS. But he was a very well-educated man, and we were able to convince him that this is not something very fatal, but we don't know what it is. We'll continue to follow it up, and probably it is a disease which it could evolve. And that was at the time when we didn't have access to the NGS at that time. And subsequently, he kept coming for follow-up initially. Then for 1 year, I think COVID started and we lost him to follow-up. And then he came back recently again. And this time, the leukopenia was still staying the same, but because we had this access to NGS, we offered him that this probably could give you a diagnosis. And at least we were able to identify that he has this myeloid mutation in him, and we labeled him as you have idiopathic cytopenia, so far unknown significance. So we'll keep you under follow-up. And this again reassured him that at least finally he has a disease, but it doesn't. He has a condition which doesn't require treatment. Yeah. So this was another of a person who had come to Kerala for a routine visit, and he had a minimal thrombocytopenia for which we were not really very bothered, but the patient was very anxious. He just wanted to find out what is the cause. We tried reassuring him, but he was definitive that he needs some cost to it. So we did the marrow. Marrow came as normal. He had some giant platelets. We assured him nothing is wrong. The whole exome sequence was able to identify this variation in this gene, which we have relayed to him with the risk that he might have an inherited arrhythmia syndrome. So it has made him more alert, and he's done his screenings and all, but he is aware of this condition, and it has at least given him some uh, plan as to how to plan his yearly checkups. This again is one of the patients who was a doctor by profession, had high counts, high hemoglobin, came to us. The other center had already done the marrow, the cytogenetics, and the fish. He came to us. We had nothing much to offer him. We said we'll do the whole exome and see if any other clonal markers are there. And before we could get the other reports from cytogenetics and fish, we had this report from NGS, which helped us assure him that he only has a low risk polycythemia. And this gave us time, faster report, reassured the patient, and we had a diagnosis at the earliest. This baby was also particularly very challenging to us. So she, for 6 years, has been coming almost every month. The child and the mother are in the hospital. The husband and the wife have a difficult relation because of this undue stress in the family with this child's routine visits. So what she has is this thick rashes that she has is and itching, continuous itching that the parents are have to stay up in the night. It affects their daily work tomorrow. So this was a very difficult situation for the family. 6 years they've been going up and down. The dermatologists have tried all these emollients. They've tried local steroids. Occasionally it comes down, but the itching is very painful, difficult. She can't go to play. She doesn't go to play because of this rashes, and children poke fun at her, and she always has to itch. So difficult for the child, family, everybody. She came to us because of this high eosinophil. Initially, anybody would have just told that it is reactive eosinophilia because you have these rashes. But then, because of this highly unlikely possibility of job syndrome, which could be there with high eosinophilia, we ended up doing the whole exome sequencing. And even though it is a variant of unknown significance, we gave importance to this particular mutation. We told them that we'll treat it. We have treated with high dose steroids. That's what we did. And I think now, fine, not high dose, low dose steroids. And it's been a year now. Child is normal, family is okay. They just come once in 3 months for a visit. Steroids I am unable to taper off and stop, but at least it has made meaningful difference to them. They didn't have primarily a hematological problem with which they would have come, but this tool has helped aid all their problems. So I'm very much in favor of this. And it can also pick out other mutations which will help you plan out your own health and life, including your family's health. So sometimes we get this information about BRCA mutations, which we discuss with the family that this is there and you need to keep on doing your screening. So these are other utilities of this tool that we have. Yeah. And we see a lot of polycythemia patients in our practice, and many of them have a JAK2 mutation. But this particular gentleman ended up with an erythropoietin receptor gene mutation, which at least told us that this is not polycythemia vera. And this is something we just let it be. We didn't advise them any section for now. And we have advised them to get the family to screen to look for this erythropoietin receptor mutation. So these are non JAK2 polycythemias, which are also likely there in the community a lot, which we need tools like this to investigate them. This again, another, yeah. So this was the patient who we diagnosed with AML, and we initiated treatment with a potential plan to do a transplant for him. But then every time we gave him this, the first cycle, we were unable to give him because of the skin infection that he was having. We gave him a low dose hypomethylating agent. He came out of it, the skin infection improved, and we decided to give him a high dose, sent him home. He didn't have enough finances to proceed with a transplant. He required a transplant. But by the time he went around asking opinions and taking treatment elsewhere, he again came back with another severe skin infection. And we had already sent this at baseline to supplement our prognostication part. And these were the reports that came. So possibly his skin infections were due to this compound heterozygous mutation that he was having here for this particular syndrome. Uh, and unfortunately, that infection worsened and we lost him. Uh, but in a young person, if you're able to give this kind of information, it gives some reassurance to the family that this was beyond what we could have planned. It probably gives them some kind of conclusion as to what happened with their patient. So this was unfortunate. We lost him, but at least we utilized this information to 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 bring about a closure in the family's minds. Yeah, I'll skip this one. Yeah, so this is another child who came to us with a family history of thrombocytopenia. The father was treated at a tertiary center elsewhere and diagnosed with ITP much earlier. When he was 20 years, it was diagnosed. Now he was some 40, 60 years old. Platelets always remain more than 30,000. So he was not on treatment, but labeled as ITP then based on the marrow that time. Now he came with the child again with some ecchymosis and minimal. He came with wheezing, but the pediatrician, because of this family history, sent it to us. And with this patient's father's history that we had, we offered them that we probably could. We also need to rule out an inherited platelet defect. So we ended up doing and identified this mutation. This, though heterozygous, helped us diagnose the father, who is now homozygous for this mutation with Bernard Solius. The other child also we did. That is also heterozygous. So it reassured the family that the children don't have a problem, but it also helps them with their planning further, also diagnose their father out of this. Yeah, so just like that other gentleman in which we identified this arrhythmia syndrome, this was another mutation which was picked up in a chartered accountant who had come, and he had this. We After getting this report, we traced back this history. There were some unexplained deaths in the family, so we have heightened his we have made him sensitive to this particular mutation that he has and to monitor himself, do a holter. His checkup is so far normal, but at least now his lifestyle, everything, he's been able to plan it out. Yeah, this is another doctor. No, this doctor was being treated 6 years back, diagnosed in view of anemia as a myeloproliferative neoplasm based on the marrow. Initially offered azacitidine, treated with azacitidine, no response seen. And during COVID, he got lost to follow up, didn't go back to that original institute. And after COVID, now because of that anemia was persisting, and he was nearby, he decided to come for another opinion here. And we told him we again have to do a marrow because we are not convinced about the fact that the disease has remained stable without any treatment. And he agreed at this age. He was 83 years old. He agreed for getting the marrow done, and we did the whole exome. And this his reports did have a high retic value. There was no other feature of any other hemolysis, but this was there. And we identified this variant in G6PD deficiency known as this Kerala Kalyan variant, which apparently is common in Dr. Vinod's group, that they have screened many people with that. And for this doctor, it gave him a closure to his problem. So it is a hemolytic anemia, not requiring transfusion. You can leave it at it is. It is a G6PD deficiency, so he needs to screen his family. But at least it brought a closure, even though so late to present. But at least it's a closure to his problems. There are many more cases, but I think I'll stop it at that. And my sincere acknowledgement and thanks to Dr. Vinod and his team, to Vignesh, for this. And it's not only reporting. There is this continuous feedback which refines the report, and I'm particularly thrilled to be part of it. And thank you, Karkinos, for facilitating it and for the session today. My gratitude for my patients also I express at this time. Thank you so much.
Thank you, Dr. Chepsy, for this insightful presentation. I would request you to take down this presentation so that people can have an interactive session with you. And audience, the floor is now open for questions. You can put the questions in chat or can ask in person. Um, I can take the first one. So, looking at so many success stories using the WES data for these patients, for which diagnosis was really inconclusive. How do you think that this uh, application of whole exome sequencing would change the molecular landscape of hematology malignancies?
Yeah, thank you for the question. So, like I told you, I've shown you only the success ones. So there is still a group in which we still have not identified. So this is not going to be a panacea for everything, but a significant proportion of patients will benefit from diagnosis with utilizing the whole exome right now. So we are all servants of science, so we have to be really guarded with our approaches. This is definitely going to be a tool which is going to be utilized more and more frequently, but it has to be done in a very scientifically, and the, it has to be thought out. You get a lot of readout, but you have to really work it out with the clinician and the lab colleague to really come to the diagnosis. So the pitfalls of it is you might get a readout which will give you 100 other information which will just throw you off. So I am not wise enough to tell you how this is going forward. Maybe all of you might know better how this is going, but I know there is a huge potential for this, particularly in a country like India where it can give us a one-stop test for diagnosis, prognosis, as well as therapy. So I am very much hopeful that this is going to change the landscape, but I am guarded because it should not be misutilized. And if it gets misutilized, we'll end up spoiling the reputation of this test, and it will just we lose a lot of years if we do that. So it has to be very scientifically done. Yes.
Well said. So yes, we have first question in our chat. What is your take on oncogenes and tumor suppressor genes? Will this impact your clinical decisions in treatment modalities in AML and ALL? And how will the WES impact the clinical decision?
Yeah. Thank you for that question. So there are certain mutations and drivers that we already know exist. So beyond that data, I think this currently we'll have to tease out and connect it with the phenotype and add to the growing armamentarium. So what exists we already know, and 100% it is going to affect our treatment decision, because if it falls into a high risk phenotype, we will offer a transplant. If it doesn't, or if it has a targeted drug, we will definitely offer a targeted drug for that mutation. But the many other information that we are getting, we probably have to collate all of that, look at it at the Indian setting, which also is important, because we don't have to religiously follow everything from the West. But if we have our own data, we can strategize these correlating gene driver mutations or the tumor suppressive genes, if we are seeing them, and create a panel which will at least help us therapeutically, I don't know, but at least to diagnose correctly and choose with the available options. Amongst the other options, many of it, even though it exists, are not available for use in India. But at least, like if I have a P uh, tumor suppressor gene, if I have P17, if I know it's very bad risk. And if the patient really is struggling to find it hard to do a transplant, I might not push him for that, because there's not going to be much of a benefit for him. Unless he can really afford it, I won't push him. So in India, I might use it to manage my patient's finances to bring about the best outcomes. But for science per se, the question that you asked is very relevant, because it will help us tease out more therapies. I know I'm not answered it fully, but that, to my knowledge, that's all the best I can.
Thank you, Doctor, for the answer. I cannot find any question, but I'll give time to the audience to give some more questions. Yeah, okay. So recently, few genes associated with germline predisposition to hematological malignancies have been uncovered. Have you encountered any such Indian families with a monogenic hereditary cause?
Yeah, so I think if Dr. Vinod is there, he would be better to answer it because yes, he keeps pointing out mutations which have been identified, but this is a very very evolving area, at least to our population, and the way we handle this data needs more sensitivity from our side as to how we share the information. And I think right now we are in the process of collating this data and identifying which are these mutations which are giving us higher oncogenic potential. And I think we need to get it peer stamped, presented, and as research findings before we are able to educate the masses, because these tests are done for something else. We end up with another information. The way to handle it, ideally, I think you have these frameworks on how to handle this, but there's hardly any genetic counselor available in most of the institutes. And if you burden one particular center, it might become too much. But yes, it is there. I have not shown anything in this. I think I showed one report done for something else, and we picked up this BRCA mutations. But it is there, and if Dr. Vinod could add on to it, he would say that he is intrigued by the frequency of it.
And one attendee has a question. Did you consider copy number variation in classifying patients as pathogenic or not?
So, like I told you, I'm not an expert in this. I get this reading. I discuss with Dr. Vinod and Vignesh, and they have this the way they go about it, and I'm assured that the readouts fulfill the criteria for it to be labeled as such. So I'm not an expert. I don't have the right. I can't straight away answer it, but I'm convinced they are doing the process are correctly in place to report it as such. Yeah.
Okay, I think Dr. Vinod has already answered the question in chat. Okay, so I was really intrigued by the finding when you said polycythemia with JAK2 and without JAK2 mutations. So what is the treatment when the JAK2 is not found?
Yeah. So there's no answer to that. It goes by the opinion, the personal opinions from the experts in this field. So the uh, Mayo Clinic is where the maximum research has gone into myeloproliferative diseases. So the way they approach it is that if it is JAK2 negative, they don't offer cytoreduction or venesection upfront unless the patient has hyperviscosity syndrome. So that is what we also practice here. We don't chase the venesection part. We let it be, and we inform him that if he have symptoms like heaviness of head, tightness of chest, we'll attempt a venesection. If there is a therapeutic response following that, that means that symptom was due to the viscosity, and then we should regularly follow it when that symptom arises and not chase the value. That is our policy. We don't have any hard data to back it up, but we intend to present our experience at among peers and possibly add on to how to approach such kind of questions. Yes.
Looks like audience is happy with the deep insights on genomics and hematology. I'll again wait for some time for the questions to arrive. Let's see if we have anything here. Okay, so I might take this chance to ask one more. In one of the case study, you mentioned that in one patient there was one VUS where you choose to provide the steroids to the patient. How did the VUS information?
Influence that
Ah,
decision.
yeah.
Yeah. So the how we went about that was the child with that skin rash and that itching, which was very, very disturbing with a high eosinophilia. So we just knew that this was not Job syndrome because that would have been a homozygous mutation there. So we labeled it as a hypereosinophilic syndrome, and there is this clonal marker to back it up. And the treatment for that is, other than cytokine reduction, is steroids. So that is the way we took it at. And since it was a very desperate situation for the family and us, the steroids was offered as a choice, and it was a dramatic response. Within a week, the family was really thrilled with what had happened, and we had ruled out every other malignancy. So many a times we have to practice what is best in our resources, and this is an example of that. Now, if somebody from the West has to comment on it, they probably would be upset in our approach, but we have to do what it has to be done. So that's how it is. We'll try our best to taper and stop it. But right now, the family is, it has been very helpful there for the family.
So with that, thank you, Dr. Chepsy, for your precious time to enlighten us on the significance of genomics in clinical hematology. With that, we conclude today's session, and thank you, Dr. Chepsy, again for sharing your knowledge and insights with us. I would like to extend my sincere gratitude to all the attendees for their active participation. And our next webinar would cover genetic counseling for whole genome sequencing by Dr. Jyoti Vajpayee Dikshit, scheduled for June 22nd. We hope to see you there. Thank you again.
Thank you so much. Thanks.